it's not fair because I'm coming from San Diego, so the weather is not that much different, but still a pleasure, really a pleasure to be here. The biggest difference is that you see the sunrise in Puerto Rico and you see the sunset in San Diego, so that was really nice. What I've been tasked to do is talk about afatinib in head and neck cancer for about the next 12 to 13 minutes. So I'll try to cover a fair bit of data in a relatively short period of time, but of course, more than happy to take questions afterwards. We'll cover three main areas, and that is the biology of afatinib or head and neck cancer as applied to afatinib. We'll look at second-line recurrent metastatic disease, and then I'll finish by talking about the use of afatinib, or at least the study of afatinib as an adjuvant. And I'm pressing the wrong button. Okay, so this is familiar to you. You've seen similar slides, the family of HER or EGFR or ERB, however you want to call it. We know now that EGFR is expressed very highly in head and neck squamous cell carcinoma, especially HPV negative. We know the biology of HER2 does not involve ligand binding, and we know the biology of HER3 does not involve a tyrosine kinase, or it's a TK dead receptor, and so ERB3 or HER3 requires dimerization with one of the family members, and that appears to be for many cancers, preferably with HER2 and activating the PI3 kinase pathway. We'll talk more about that in just a few minutes. We know that there's a broad array of dimerization partners, and that dimerization actually may lead to different downstream signaling depending on the partnership. And then, of course, that afatinib does inhibit irreversibly de facto all four members of this family, because by inhibiting the tyrosine kinase domains of ERB1, ERB2, and ERB4, it also de facto inhibits ERB3 because of what I just said about its dimerization requirement. And so we started studying afatinib in squamous cell carcinoma of the head and neck for fairly obvious reasons. Prior EGFR inhibitors had shown efficacy in this disease. We know the importance of EGFR biology to this disease, and it was no surprise that indeed afatinib was effective in several cell line models. Here you see xenografts of FADU and HN5, and what was interesting is that not only was the drug effective and quite effective, it was actually most effectively applied as a continuous dosing in the mouse models. These are xenografts, of course, but it was also appeared to be more effective than other similar EGFR inhibitors. Here you see in the HN5 model, which is, by the way, an EGFR amplified cell line. You can see that afatinib is universally effective in all the mice treated, while other similar agents were more or less effective, and in fact some of them, such as lapatinib, completely ineffective, again in an EGFR amplified model. So suggesting that it's an agent that at least has some utility in this disease. Let me step back a second, and for those of you who don't treat head and neck cancer on a regular basis, let me just remind you of what currently are the standards of care, or at least the algorithms that we use in the clinic. And this may be a little bit difficult to see. It's a paper that Tina Sacco and I just published in JCO, and this is one of the figures from the paper that really attempted to define the approach or a standard approach to patients with recurrent metastatic disease. And it's primarily based on, as you might guess, not biomarkers, but things like availability of agents, their tolerability, the patient performance status, and so on. And the point of it is that for patients who are fit, we will use either doublet or triplet chemotherapy in the first line. For those who are less fit, we use single agent chemotherapy. And for those patients who go on to second line, and that's what I'll focus on for most of the rest of the talk, it's usually single agent chemotherapy, cytotoxic chemotherapy, and sometimes cetuximab, which of course is approved, at least in the United States, for either first or second line recurrent metastatic head and neck cancer. That's the point of the slide, and it introduces some of the clinical trials that now tested afatinib in the second line recurrent metastatic. The first attempt in head and neck cancer was a randomized phase 2 study comparing the drug to a standard of care, cetuximab, a monoclonal antibody, of course, that targets EGFR. And the hypothesis here was that afatinib would actually lead to a greater degree of tumor shrinkage. And we use tumor shrinkage for primarily statistical reasons that I can discuss if anyone's interested. But the hypothesis that afatinib would be a better drug in this setting. And the setting was patients who had prior exposure to cisplatin in the recurrent and metastatic setting, who had clearly progressed on cisplatin. So these were not patients who couldn't tolerate platin, but who actually progressed and then became eligible to be randomized to either afatinib versus cetuximab. And here you see the consort diagram showing you the flow of the patients through the study. I'll draw your attention to the bottom of this slide because one of the nice aspects of the study was a crossover design. Patients who had progressed on either arm could be enrolled in the converse drug. So cetuximab progressing patients could receive afatinib and vice versa. And we'll talk about both stages in just a moment. So the hypothesis was actually demonstrated. In fact, afatinib did lead to a greater degree of tumor shrinkage, as you can see from the waterfall plot, than cetuximab, arguably not dramatically different, I would agree with you, but it actually was different. If you look at the mean, the median, and the number of patients that experienced tumor shrinkage, I can tell you that there was no difference in progression-free survival. I'm not showing you those data, but there wasn't. But again, I'll draw your attention to the bottom part, that is stage 2. And what was striking to us was that there were clearly patients who received drug A that still responded to drug B. And if you look at the afatinib part of this slide, and that's here, you actually saw a few patients who had been exposed to cetuximab, the monoclonal antibody against EGFR, who responded to or had tumor shrinkage to afatinib, suggesting that there is not universal or complete overlap in the mechanisms of actions of these drugs. Here's another way to show very similar data, but I think this illustrates it a little bit better. And again, I'll draw your attention to your left, to the left-hand panel. These are patients who had cetuximab first and then went on to receive afatinib. Cetuximab is the blue line. The green line is afatinib. And again, demonstrating that now there were several patients who went on to receive afatinib and at least for an appreciable period of time, suggesting again that there may have been benefit. Well, with that in mind, we went on to do a phase 3 study, international trial, comparing afatinib, again in the second line, so similar group of patients, platinum refractory, to a standard of care methotrexate. Oops, going the wrong way. Eventually I'll get there. Here you see the study design, a 2-to-1 randomization, afatinib single agent versus methotrexate single agent. Primary endpoint was progression-free survival. And again, we can talk about the reasons behind that if there's interest, but of course we looked at overall survival and the others. And what we saw was a difference in progression-free survival that was statistically significant. But as you look at these curves, even from the back of the room, I think you begin to wonder, well, is there really a clinical meaningful benefit here? And of course, that's debatable. I'm not going to give you the answer to that question, but suffice it to say that there was a difference that was statistically significant, at least on the log rank test. Moreover, afatinib clearly demonstrated a higher response rate and a higher disease control rate than methotrexate, 10% versus about a 5% response rate. That incidentally is exactly what you'd expect from methotrexate in this setting, about a 5% response rate, but no difference in overall survival. None whatsoever, p-value 0.7, hazard ratio at unity. And what surprised us about this study were really two things. As you look at these overall survival curves, first of all, the median overall survival for methotrexate was 6 months. We didn't expect that. We actually expected it to be about 4 months, and 6 months we didn't think we'd achieve with methotrexate, but obviously we did. And that underscores the second point I want to make that I'm not showing you, but that 50%, 50, of these patients went on to receive third-line therapy. the paradigm in recurrent metastatic head and neck cancer, we had always thought was that if you see a difference in progression-free survival, especially in the second line, you'd certainly see a difference in overall survival because these patients don't go on to receive third or fourth line therapy. But as the prior speakers also commented on, we are seeing differences in an evolution of this disease. And again, 50% of the patients went on to receive third line therapy, perhaps explaining why overall survival was not met. Not surprisingly, patient-reported outcomes were a big part of the study, and not only was PFS different between the two arms, but so were these pre-specified patient-reported outcomes, global health, pain, and swallowing, all in favor of afatinib, suggesting that perhaps in this setting, progression-free survival and response rate did mean something to these patients, and maybe we shouldn't completely discount the small numeric difference between median PFS in the two arms. Well, of course, for a marginally positive study, I think that's probably the best way to characterize the randomized afatinib trial, we begin then to look at which patient groups benefited. And these data are about to be presented in Singapore next week, but I'll give you a preview of some of it, looking at biomarkers and specific patient groups. Here's the forest plot for PSF, and I'll highlight just a couple of things. First of all, the prior use of EGFR, and secondly, age. Age, because it seemed like older patients benefited from afatinib, suggesting that maybe this is a good option for patients who are over 65. An oral agent that they don't have to come in for may be actually more pleasant for an elderly population versus younger patients. I'm of course editorializing here. But the other thing to notice is the prior EGFR therapy. And although I demonstrated to you that there may not be complete cross-resistance between cetuximab and afatinib, in this study, it was clearly the patients who had not received a prior EGFR inhibitor that appeared to benefit from afatinib versus methotrexate. So with that in mind, here you see the graphs of the point I've just made, but we also looked at biomarkers, and these were all pre-specified biomarkers, and a few things jump out at us. First of all, it appears that the P16 negative group were the ones that benefited, so HPV negative. And secondly, it appears that patients who had an EGFR activated tumor, as exemplified by EGFR amplification. I use the word amplification here a little bit loosely. It's actually gene copy number and amplification, and I can talk to you about the assay if you're interested. Fred, don't ask me any sophisticated questions because I won't be able to answer you. But along with that, a PI3 kinase pathway that was inactivated, or let's say less activated, as exemplified by low HER3 and intact PTEN. PTEN, of course, is a tumor suppressor of the PI3 kinase pathway. That was the group that appeared to benefit most from afatinib versus methotrexate. And if we put this in a cartoon to illustrate the hypothesis, what I think we were really seeing was that tumors that were, again, EGFR activated, so HPV negative, and we know that EGFR is important to the biology of HPV negative disease, EGFR amplified, and an intact PI3 kinase pathway that is not driven by activating mutations or amplification appeared to benefit the most from afatinib. I know, Everett, I've run out of time, so I'll just leave you with two more points very quickly. First of all, squamous cell carcinoma of the head and neck is a curable disease for 90% of patients. 90% of our patients will present with local or regional disease, and therefore, if we're really going to make an impact in head and neck cancer, we should do it in these patients. And that's what we're trying to do now with afatinib, in fact, well underway. Here is an international randomized study comparing afatinib to placebo in patients who were treated with locally advanced disease by chemotherapy radiation, who were rendered with no evidence of disease after curative intent therapy, but were still at high risk. These are all stage 4, primarily HPV negative. If you're HPV positive, you have to have a significant smoking history. So so arguably a high-risk patient population, randomized in a 2-to-1 fashion to afatinib versus placebo. This study is actually, I'm happy to say, almost complete accrual. We'll certainly finish accrual in 2016, and of course, we'll see the data a couple of years after that. Here you see the numbers. We expect that we'll finish accrual in the near term. So with that in mind, I'll leave you with a few thoughts that really afatinib does have activity in head and neck cancer, but in an unselected patient population, clearly meaningful efficacy above the standard of care was difficult to demonstrate. And that high-risk locally advanced setting may provide greater utility for several reasons. And of course, that phase 3 trial is ongoing and will soon complete. And then a little bit of dreaming here. If I could do it all again, and of course, many times in life we don't have the opportunity to do it again. And unfortunately, I don't think we'll have the opportunity in this case. But if I could do it again, honestly, I would exclude HPV positive patients. I would exclude patients with activated PI3 kinase pathway and discuss some biomarkers around that. And I would enrich the population to either for or restrict to high EGFR gene copy number. And perhaps we would have had a more positive study in those circumstances, but it is what it is. So thank you very much for your attention. Thanks again for the invitation. Should I stay up here for discussion?
I think, yeah.
Okay, thank you.
You're coming back.